All right. Thanks everyone for coming back on time. Please sit down if you aren't seated already. I'm now going to hand it over for our next session to Disha Agarwal from the Gates Foundation, the Gates office in India, for our next session on, next slide, on community-based demand generation interventions. Thank you.
Thanks a lot. Okay, so till the time that people are trickling back, and I understand it is a tough session post lunch, and that too, most of the delegates are suffering from jet lag and things like that. So, and more so, this is a session on demand, and demand has had issues in gathering attention from public health managers over the years. So I've just put together a slide. Can you move it nicely? To just focus on how important demand is for any public health program. On the first slide, you can see people moving to a gym center on an escalator. So they have the intent, they are going to work out, but then, and the stairs are available, but still they are using an escalator. So that brings the emphasis on how important it is to understand the psychology behind the psychology of human, what needs to be communicated. In the second picture, you see that the toilet has been built. It is a toilet. That is not very clear, but yeah. And the person clearly seems very confused, very disinterested, disengaged. So this is a true experience from a toilet initiative in India, where toilets were built, but then there was no awareness generation activity around it, and so most of the toilets were left unused. Then they realized that it is equally important to generate some demand and awareness of how important it is to have good sanitary facilities at home. And then the program was successful. In the third picture, you see the mode of communication. The messaging is right that you need to get the polio vaccine, but then it is being conveyed in such an intimidating manner that it can terrify anybody. So just to emphasize that the mode, the platform, the way you communicate your messaging, that is so important. And the last one, where the doctor is telling the person that you need to touch your toes 20 times a day, but then the patient is like, no way, my cap will fall off. Just to convey that your intent, your thought process might be right there with a good intention, but then what is of priority to the patient might not be very aligned. And this has been our experience with all the zero dose learning agenda activities. So what is the priority to the beneficiaries? And in the run-up to this session, also the other sessions were getting to reflect on the importance of demand in the community and things like that. So with that, I guess I'll invite my panel. So the panel will be presenting on the demand interventions, the work which has been done by applying human-centered designs around zero-dose learning agenda, where they have tried to understand the drivers of not getting vaccinated, co-created solutions in participation with the community. And when I say community, it means all the stakeholders, the program managers, the beneficiaries, everybody. And then co-created some solutions, some interventions to increase the uptake of vaccination. And the teams over here will be presenting the financial as well as the programmatic implications of having these human-centered designing or demand interventions. And so that will be the overall, that is the overall context of the session. And with that, let me invite Dr. Alan from India. So he is steering the urban immunization strengthening project in India, which is being implemented in some selected districts of two of the most populous states of the country, Uttar Pradesh and Bihar. And under zero-dose learning agenda, he's steering the costing and the behaviorally informed human-centered interventions for the zero-dose children in India for the urban community. So with that, on.
Thank you, Dr. Disha. Yeah. Maybe I'll give you a broad context about from an Indian perspective, from where we come from. The latest unique data was released last week, and we know that pentavalent coverage is something around 96%. So the country's immunization coverage has matured a lot. So, and also, but what remains missing is that the absolute number of zero dose still remains the highest. The unique data suggests that there's still around 900,000 children who are in the zero dose category. This is based on whatever we know from the recent Munich updates and also from all the DHS surveys that has been happening. With this, what we know about costing related work in our context is two studies, both of which Logan has been a part of. Which is the first study talks about the variation in delivery cost across the country, which says that for routine immunization it takes something around $1.3 to around $2.9 per child reached per dose. And on the zero dose child reached, when you're looking at the zero dose child reached, it's from a PD study, from a periodic intensification of routine immunization study. It talks about something around $63 per child, which is exclusive of vaccine cost. Now, a brief about the zero dose learning agenda from the JSI's India work is we are looking at from a 3D approach, which is define, design, and deliver. In the define piece, we did a mixed method study to understand the drivers on why a zero dose child exists. So we did a root cause analysis. So we found that there are, let's say, from an access or maybe a facility readiness perspective, the drivers are very less, but rather from an intent to vaccinate or demand side perspective is where most of the drivers exist, which are let's say vaccine awareness is less, vaccine PPD awareness is less. The value of vaccines is not understood by the community. There's a lot of fear related to minor side effects, and also there is a lot of gender barriers that exist in the urban communities in which we are working. So with this, we developed some, we did some co-creation, we did some testing, sprint reviews with the help of HCD experts, design researchers, and we developed certain solutions, certain interventions targeting these leading barriers that we found. One more thing that I would want to highlight over here is the Indian definition of zero dose. When we look at it from a review point of view, is we not just look at the true zero dose or maybe the global definition of pentavalent, the children who have not received DPT containing vaccine 1 at the age of 12 to 23 months, but also we look at it from a potentially zero dose child, as in a child who is around 3 months of age, and considering that pentavalent is given at the age of 1.5 months, if a child is around 3 months of age, if the child has not received the pentavalent vaccine, this child could lead to become let's say a zero dose child. So we look at it from that perspective, because this helps us for early identification and maybe early detection for our work. So this is the definition that we are looking into from a state review or also from a national review. This is the definition that we look into for a monitoring purpose. For the costing related work, costing related work is a component of the whole CDLA work that we do, and we have two objectives of ours. One was to estimate the workforce investments required in delivering immunization to routine to zero dose children in the urban settings that we are working in, which we did through a baseline endline. So endline is still remaining, but again we did a baseline assessment. We did facility-based staff interviews from the staff to understand what amount of time do they spend on immunization, specifically related to immunization. And the second objective was to estimate the intervention-specific life costing, as in from the designing of those interventions to the early rollout or delivery of these interventions. And we did through an activity-based time use matrix. We interviewed the TA staff that was involved, the design researchers that was involved, the government staff who were involved in the co-creation, in the field testing, and also the finance officers to understand the financial implications of this thing. Moving from for the first objective of ours, which is what are the monthly routine baseline costs. We found that in the 6 UPHCs are urban PHCs that we are working in our 3 districts. what we realized is the range, the distribution goes from around $27 in one UPSC in Bihar to around $98. This is the total cost related to zero dose children reached in a routine setting in this urban six urban PLCs. But when we are looking at in a cost per ZT child reached in a routinely existing in the existing systems, we see that it's something around $9 per child reached to around $17 per child reached, and the median cost something lies something around $12 per child reached. This is the I want to reiterate that this is the routine existing cost that facility is the charge that is there. Now this graph talks about the distribution about, let's say, from each of the states or each of the UPSCs that we are looking into. The cost components we were looking into was the staff time, the time it took for identification, for mobilization, for vaccination, the transport related to ZT child, the supplies related to the child. But again, these are costs which are excluding of the vaccine cost, because we will be accounting for that towards the end, and these are all preliminary baseline costs that we have. The variations why we understood was it's primarily driven by the persistent vaccine hesitancy that is present in the communities. There's a lot of entrenched hesitancy regarding the efficacy of vaccines. There's a lot of myths regarding vaccines, mistrust, distrust in the government systems. So that is the reason there's a huge range. And also you can see the children being vaccinated, the zero dose children being vaccinated is also very less. In the x-axis you can see it's around 2 or 3 children in one of the UPSCs and around 6 children in a UPSC in Bihar. So. And another finding is that the average labor time finding is around 5.5% of the community health workers' time is spent on zero dose activities. But I like to come back to this particular objective, maybe this particular point at the end of my slide. Yeah. On the second objective, which was on the intervention specific costing, on when we developed HCD-based interventions, how much time, how much effort, how much money did it cost for us to develop these behaviorally informed interventions to understand or to reach the zero dose children. I understand this is a busy slide, but what I would want to highlight over here is that the design phase, it spanned around 4 months, 5 months, around. It's a rough period, with early driver barrier identification, prioritization, co-creation workshops that we did, prioritizing the ideas that were coming out of the co-creation workshops, field testing these ideas, and trying to understand it from a programmatic lens also, whether the feasibility or the pragmatic use of the interventions will be, how applicable it will be. So the design phase is around 5 months. The rollout about it around 1 month. The rollout, what I'm saying about is the initial delivery charge from a, let's say, training perspective on let's say, if I train a mobilizer or maybe a healthcare worker on how to use that particular tool to mobilize the zero dose hesitant families, and how much time it took. So overall, the distribution across this design and the rollout phase is around 86% for the design phase and around 14% for this thing. And what we have found out from, let's say, we rolled out all of our intervention in the month of January, and it's from February to around last week of around June. There are around 382 children that have been. These are all very hesitant children who have been vaccinated based on the HCD-based intervention, behaviorally informed interventions that we have. So. Again, there are 2 things that I want to also highlight over here is we have 4 interventions. 2 of them are mobilization tools that the community health workers are using while they are going house to house, while they are trying to counsel or convince these families on what to use, on why it is essential for you to get your child vaccinated. So these are our foundational tools, which is the flyer and I would say a checkbook kind of an intervention. I'll be happy to dive more into it, let's say on a separate basis. But yeah, the total cost per child reached when I'm looking at it from a design perspective for the 2 interventions of mine, which are the foundational interventions, the mobilization tools are around $68 per child. And if I am removing the design cost, because again, once the thing has been designed, we are rolling it out. for the rollout cost is around $11 per child each. But when I'm looking at it from a bundle of interventions, consider that we have 4 interventions from a full bundle of interventions that we are, some of these interventions being, let's say one of them is engaging the fathers of the community. So that's more towards having a fathers meeting, having some religious leaders having fathers meeting, using these intervention mobilization tools just to create awareness among the male caregivers on why it is important to understand or why it's important to get your child vaccinated. So for the full bundle of interventions, for the cost per child reach with the designing and the rollout is something around $136 per child reach. So this is on what it cost us for the whole intervention specific costing. And this particular slide talks about the disaggregated design versus rollout cost. So like I was just mentioning about in the design phase, we included some design consultants who were the major chunk of the, let's say that the cost was on the HCD experts, the LOE that they charged. But considering that once the interventions were developed and we had to roll it out, the HCD experts were not involved in the rolling out because we were the ones, the JSI staff were the ones who were giving TA and training this community health workers on how to use these tools. But again, there's one more thing that I would want to highlight over here is, for example, if I'm looking at this particular intervention, which is the fathers meeting, the consultants, the designing of that particular intervention, considering the fathers meeting or fathers advocacy meetings, these are all not very novel interventions. So again, the designing cost for that particular intervention was much less. But when I'm looking at the staff time, or let's say in the rollout cost, when I'm looking at the TA for fathers meeting, that's where a lot of effort was done for coordination, for planning, for mobilizing the fathers to come to this meeting, to give some incentives to them to come to the meeting so that they understand the importance of vaccines. So this slide talks about the cost shares between all these interventions. Again, this is just a matrix. I don't want to go into deeper details of this, but what I would want to highlight is some of the interventions that I'm talking about, the foundational interventions, which is the flyer or the checkbook, which is mobilization tools, are from a design complexity, it's a very low, or let's say a moderate intervention that was there, because there was not a lot of effort that was required, because we got that idea from one of the co-creation and HCD-based co-creation workshop that we did. And also the rollout complexity was much lower, considering that we just had to train those health workers and we just had to do some shadow monitoring and hand-holding support while they were mobilizing the community. But when I'm looking at, let's say, fathers meeting for an example, for an instance, the design complexity was much lower. Again, this is not a novel intervention, but the rollout complexity is much higher because there's a lot of planning that needs to be done, there's a lot of coordination, mobilizing these fathers, finding out these fathers, also considering that we work in the urban settings. These fathers are the ones who are all engaged in the daily wage labor, so they are not found when we go to meet them. So that's one of the points that I wanted to highlight over here. What are we learning is demand side interventions, behaviorally informed interventions are very cost intensive to design, and this is something that is much needed to overcome the deep rooted hesitancy that is present, that's based on the mistrust, or maybe because of the lower awareness, or maybe because of the fear of side effects for vaccines. And what we also realize is resource intensity per se doesn't, having more sessions or having more outreach sessions doesn't per se reflect to more zero-dose child being vaccinated, considering that if you don't understand what is the root cause that exists for a particular zero-dose caregiver, if we don't understand that, okay, they are the main cause is side effects, or maybe the main cause is there's some myths that's surrounding in that particular community, in that particular slum that we are looking into. If they don't address that particular issue, there are no amount of outreach sessions that we place or maybe conduct, that's not going to help. And one more thing that I would want to highlight is, earlier I mentioned about the average caregiver spends around 5.5% of total time, but that's this masks what's effectively there when we do a deeper dive. For example, just an example that I want to give is, for example, one of my the PHC that was looking into, there is around 119 sessions that are being held up in a month. But in those 119 sessions, not zero-dose children are not found in all of these areas. They are found in particular clusters. So in those 119 areas, that's around only 32 clusters that are there, and around in the 14 auxiliary nurse midwives or the vaccinators that are placed at the UPHC or in the PHC, around 6 of them only have the areas which cater to zero dose clusters. So in those areas or in those areas or in the areas where there is community health workers, there is clustering, or maybe there's more of zero dose areas in that particular area. And at that area, those healthcare workers take around 20 to 30% of time trying to engage with the communities and trying to make them understand or counsel them on the importance of vaccine. So again, when we look at it from a UPSC lens or maybe from a BHC lens, the average time is around 5.5%. But when we do a deeper dive on which particular community health worker, how much time it is taking, that's around 20 to 30% trying to convince them, and still they are not being convinced. So effectively, I would say this is the cost of, let's say, inefficiency of, let's say, because routinely it's not been, these children are not being able to be converted. From a policy lens, what we understand is that then these are all preliminary analysis concerned that we are implementing this thing right now, and we are at the stage right now in which around in the 2 months is when we'll be doing the exit interviews also. What we understand is that cost per zero dose child reach is much higher than cost per routine immunization. So again, I do believe that the cost of the marginal utility is something that we will also have to understand. We understand on how much effort it's there, and higher effort also doesn't always equal to higher conversion, specifically in those areas where there is a lot of hesitancy, or maybe the root cause is maybe different. Maybe it's not an access related issue, or maybe it's a demand related issue. And also, there's a need to recognize and support these mobilizers, these caregivers in high burden zero dose clusters, because blanket averages or maybe costing of blanket averages that might mask this local workload and resource needs. What's next for us is the exit interviews, and also we are also trying to look at, considering the ZDLA approach. There's a continuous reiterations of the interventions on trying to understand how this intervention is moving forward. What is the community's acceptability of this intervention? How many children are being converted? So we also do user advisory groups, on a monthly by monthly basis. So next for us is also to estimate the cost of continuous learning and iterations. Yeah, that's about it. Thank you.
Thank you, Alan. With that, I'll welcome Devak. He works with the Clayton Health Access Initiative in India office, and his major expertise is around strengthening data systems and governance mechanisms for routine immunizations, and that too in two most populous states of the country. He's leading the efforts to understand the cost and cost effectiveness analysis of HCD-based targeted interventions for the zero-dose children in high-burden regions of India. And this project is also part of the bigger zero-dose learning agenda initiative, which my colleagues in the earlier sessions have also alluded. So yeah, that would be great.
Absolutely. Thank you. Good afternoon, everyone. I'm Devak. Grateful for the opportunity to speak today about the cost and cost effectiveness of our HCD-based interventions in the rural hinterlands of Uttar Pradesh and Bihar. So our approach towards the Gates Foundation-led zero-dose learning agenda follows 5 phases particularly. Given that the API program in India is fairly mature and has been around for approximately over 3 decades, we wanted to first understand what are the systemic gaps that are still persisting. Despite 96% coverage, why are zero doses still remaining? Beyond that, we've gone on to work with communities to understand what are the root causes behind these barriers and work with them to create solutions. Right now, we're in the design phase where we have tested the prototypes that have been developed for communication collaterals, and we're currently implementing them across 120 facilities spread across 4 districts in India. And we are following rapid agile learning models by learning by doing to constantly improve our processes. Towards the end of this year, we hope to package all of this together into the most effective interventions that we found for a sustainable adoption. Now, throughout this value chain, human-centered design and behavioral science has been at the heart of it all. be it unlocking system level one thinking by participatory games with caregivers and healthcare workers. Sometimes these discussions lasted more than 2 hours as well with a single caregiver to understand what are the true root causes that could be affecting vaccine uptake among them. Beyond that, we've co-created ideas not only with caregivers, but the frontline workers, healthcare workers, major community influencers to understand what could be the nudges that we could use to help them prioritize vaccination. And eventually, we've also done prioritization of different ideas that came up with program managers for these hyperlocal communities. Now, we keep talking about these demand generation interventions, but what are they actually solving? Now, if I go by the EGH framework, we uncovered a lot of barriers when it comes to intent, access, readiness. The interventions that have been eventually prioritized and rolled out under our work deal with primarily 4 themes, which is helping zero-dose caregivers understand the importance and urgency of vaccination. Sometimes that is a miss. And also allaying widespread AEFI fears. The fever you get after pentavalent 1 is a major driver of people not vaccinating their children. Making it easier for them to track their child's vaccination journey, increasing awareness on where and when to seek services, and of course, improving the system capacity for not only better mobilization, but I would say a better service experience, which has proven to matter quite a bit. Coming to the costing side of things. Now, as opposed to the approach taken by GSM, we're primarily just focusing on incremental costs, not the system level costs already being incurred for immunization. Incremental cost only of our interventions, which is split across this framework that you see, across intervention design and rollout being split further into initiation and implementation. I wouldn't delve deeper into all the aspects, but what I can tell you is that we have considered financial costs and opportunity costs as well of time spent, be it by government stakeholders involved, HCD consultants that have been onboarded, or time spent by child staff as well. Financial costs include transportation, printing, workshops, etc. Now, these are some of the initial findings that we have from the costing analysis. Mind you, this is an ongoing project, so these will become more robust over time. I would bring your attention to the left side of the screen first, which is in the morning there was a lot of discussion around different approaches and how costing could vary across geographies. This was very interesting for us as well because the total cost per facility that you see across our 4 sites, this is an exact same process that we followed, but in Uttar Pradesh the cost is much lesser as compared to Bihar. And this has happened primarily because of topographical challenges, administrative challenges that are hiking up the costs that we're seeing for reaching zero-dose children or implementing these solutions. In terms of the distribution across phases, I think this came out very strongly in Alan's presentation as well, is that we do expect rollout to represent a significant chunk of the pie, but because of how rigorous HCD is, we see design and prototype testing representing a significant chunk of the pie as well. When we delve deeper into it across components, we see major drivers between procurement, workshops, supervision, M&E, and HCD consultants. There is one piece of information not listed in this, but I think the group can benefit it after hearing the discussions today, is that when we look at the pie between opportunity costs and other costs, if I just look at this binary, 70% of our costs are actually just opportunity costs that have been factored in. Now coming to the cost effectiveness side of things, we are trying to look at 3 primary outcome indicators for measuring cost effectiveness. The first one would be additional zero-dose children reach. For this, we will be depending on the government administrative data set, which is HMIS, and triangulating it with other sources for validation. We want to use interrupted time series regression on pentavalent 1 and DPT doses. Why time series regression is because we want to account for seasonal variations as well, and the possible loss of RI doses that may have been administered if the intervention was not there as well. In terms of depth awarded, we want to utilize the LifeSafe tool, and we will be extrapolating this at a sub-national level, given the constraint that is there in the tool, that we are not able to do this at a hyperlocal level where all our interventions are at right now at a district level. Similarly, for DALIs averted, we would be using tried and tested methodologies for converting deaths averted to DALIs averted. And one important thing to factor in for deaths averted and DALIs averted is that in our approach, we are looking at the benefit across all vaccination doses for the 0 to 2 year cohort. This is, to be fair, because FETA1 or DKD1 may be the proxy indicator for zero dose prevalence, but when we look at vaccine uptake as a whole, we expect these interventions to increase that. We'll be depending heavily on the global burden of disease study for our DALI estimations. Now, after 2 months of implementation in one of our ZLA sites, which is East Champaran in Bihar, these are some early signs. Please take them with a pinch of salt because I realize it's pretty inflated right now. The cost per additional ZT chat reached is coming to around $501. There are 2 things of note here. One is that the costs in the numerator have been accounted for the entire time duration. So all different kinds, it's a very robust numerator. But when we look at the denominator, it's underrepresented. We expect the benefit to progress more and more over time. And that's why we expect this overall cost per additional ZT child reach to further diminish. And we're looking at a 6-month implementation timeline, in the middle of which we are in right now. But we also want to project benefit beyond this, because it will have a long-lasting impact. The second thing I want to consider is the technical assistance costs. So, child EA costs have also been factored in, which proved to be a significant chunk of the pie. What we do want to do is, when we're trying to benchmark this for government feasibility, we want to benchmark it against their own standards for travel, venue bookings, etc. All these options that we've taken, we want to benchmark it against government standards itself. Learnings and challenges. Now, I can go through this table in depth, but I think what you can benefit from instead is some real-life examples of challenges that you can encounter. So I'll talk about 2 examples. One is that we're doing purposive sampling amongst all the frontline workers and healthcare workers to understand what is their remuneration, how much time are they spending on immunization activities, or how much time are they spending on delivering our interventions. Now, it just so happened that the governments of UP and Bihar had not paid the incentives to these workers over the implementation period. So when we actually went to collect data, it created a lot of issues. They would not answer our survey properly, and we had to delay the timeline for that. So similarly, on the benefit side of things, we're looking at the administrative data set of HMIS, which suffered from downtime in the first 3 months of this year. So it is very important it's been a huge learning for us also to have a very adaptive design to prepare for not just a plan B, but a plan C as well. Going forward, we will continue collection of these costs to make them a lot more robust, benchmark the current estimates for TA against government standards, triangulate data sources beyond the administrative data set to also look at what is the benefit of these interventions after being validated for quality, projection-based deterministic models, as I said, beyond the implementation timeline to see impact, and the benchmarking to the WHO choice threshold of the ISO that we eventually come up with. So these are upcoming activities that we will be taking up, and we hope to share some results with all of you all later as well. The idea is that at the end of the day, we're taking up this activity to benchmark the feasibility of implementation of this process of using HCD to create demand-side interventions and to create valuable cost-effectiveness considerations of the model for affecting national and sub-national policies as per standards that they understand in high-burden regions. That's all from my side. Thank you.
Thank you. That was crisp. With that, let me welcome the last speaker, Alemnesh. She's a program officer at the Ethiopian Core Group Partners Project Secretariat at the Consortium of Christian Relief and Development Association. Previously, she's coordinated a research project with funding from the Sedan Vaccine Institute, and she'll be presenting on the effectiveness and cost efficiency of active community-based surveillance augmented by referral slips on reducing zero-dose and under-immunized children in pastoralist and semi-pastoralist communities in Ethiopia.
Thank you. Thank you very much. I am here to present on behalf of the research team in CCRD just effectiveness and cost efficiency of active community-based surveillance augmented by referral slip. It's a different approach to create demand for the community regarding to the immunization and to reduce the zero dose in under-vaccinated children, as well as to increase immunization coverage. We try to create a referral scheme from the community volunteers, and that with that we try to evaluate our performance regarding to the baseline survey with the headline survey. Here is our the research teams. The community volunteers in Ethiopia, they are, members of the community because such type of volunteers are central for this project, for the referral scheme project. Therefore, selected by their wish to serve the community, expected to work 2 hours per day in today's pandemic, supported by the community for their work. Relatively non-paid but receive incentives. Not since they are volunteer, they are not paid, but mostly they receive incentives from the government, from non-government organization, also from the community. As a custom in Ethiopia, there is communal works for agriculture, and if there is such kind of activity in the neighboring regions, the community, the neighbors are helping, supporting them as a prime recipient for this. Because, in Ethiopia culture, especially, is a very big honor for someone. This is it. The community volunteers are the main actor for this towards the referral slip with health extension worker. This is context of referral slip. What we are doing with that, what we are bringing here is that, we bring 3 kinds of, where I have also the hard copy here. We plotted that, we prepare 3 kinds of referral slip. This referral slip mainly for pregnant women, for newborn baby, and relatively for a young baby. And each referral slip, it was written as tailored method. For the pregnant woman, it says that pregnant women must visit a facility for antenatal care. For newborn baby should take vaccination immediately they born. And for the young boy, we put this tailored method: unvaccinated and partially vaccinated children are exposed for disease, disability, and death. This is the tailored message what we put on this referral slip. These referral slips are printed with in one community. It's believed to have 5 community members, 5 community volunteers, and we try to print the referral slip with 5 colors, because they would be easily distinguished with the colors. For example, if I get the green color, I am green, starting from getting this referral slip. Therefore, the health extension workers know that who is referring this pregnant woman, or this newborn baby, or this vaccine for the baby. It is easily it will be distinguishable with the colors. And the cycle is just like that. Whenever the community volunteers going to house visit, they will identify if there's any pregnant mother, newborn baby, and newborn. Then after, if they get this pregnant mother, for example, they will give this referral slip that plotted with pregnancy. Therefore, the client will go to the health extension worker, health post, and she gives this referral slip. Then the health extension worker knows what she has to do, because she knows that the mother is pregnant. Therefore, what service she has to give, she knows. Therefore, she gives all the service, and she registers all the service given, and also she make education for the pregnant mother to prevent zero dose or under vaccinated children ahead of times. And after that, there is extension workers. There is a clear box in the health facility. There is extension workers just collect, reposit this referral slip in the tickler box. At the end of the month, they have a review meeting. With that review meeting, they review what was their challenge, what was their success, and what was the drawback. And they will count, together the referral slips, who is referring at the end of the month, who is referring more client than they reward with that. It was working with such kind of method, this referral slip. Okay, just this one is about referral slip. Just we were making that how it works, this referral slip, to create demand, to reduce the zero-dose children, to reduce the under-vaccinated children, and also to increase the immunization coverage. How it works, just we plan to have a research as an underline, as a baseline in the underline research. We made underline research. Therefore, the objective was to assess the effect of the CV in improving the full immunization coverage and reducing the zero-dose and under-immunized children. At the end of in the underline survey, we were also assess the cost effectiveness of the intervention by evaluating the program's performance. This is it, our objective. Therefore, our method was, CGPP is working in pastoralist area, and we are working in 6 regions. So we choose the 3 regions in Oromia, Southwest, and Somalia. Therefore, just we made a cluster randomized control trial test. Then from the region, we choose 3 waradas. Those 3 waradas, from those waradas also, we can start 4 qabalis. And from these 4 qabalis, we made it the intervention and the control group. Therefore, 12 rural qabalis with 480 children aged 12 to 23 months are participated. Actually, the mother was participating in this research. And from the control group also, the same number assigned. Altogether, we were made this research with 960 caretakers. Data, it was collected through open data case system, preloaded with the questionnaire, and analyzed in SCPSS, actually with a simple complex analysis command in SCPSS. This is a software that we will analyze the data. And what we are doing is the immunization coverage, zero-dose status, and under-immunization were compared. Then after financial data were collected, cost effectiveness was employed only in the intervention area, because we did this referral slip only on the intervention area. In the control group, we don't have the referral slip. This is the result, what we get from the data. When we describe at baseline and underline survey, you see the blue one is for baseline, and the light yellow, I think, is the underline survey. And the zero-dose child, when we see the zero-dose child, on the baseline survey, we got 2.5% zero-dose children in intervention area, 47.3 again under-immunized, and 50.2 full immunization. This is our baseline data. Then after 10 months, after we employ this strategy, after 10 months, we got that zero-dose children is decreased from 2.5 to 1%, and under immunization from 47.3 to 12.5, and the full immunization coverage is coming up from 50.2 to 86.5. Then after, when we go to the controls group, just on the baseline, we got 21% zero-dose children, 36.5% under-immunized, and 42.5% full immunization. When you see the result, the zero-dose and under-immunization rate is increased in control group, and the full immunization rate is decreased. Then what we are doing is what is the direct effect of this referral slip. we analyze the directive fit. When we say that the directive fit, just we analyze based on only the underlying finding. Therefore, from the data, when we analyze the data, what we got is in the from the directive fit, 31% of the Europe children were increased, 27.9% of under-vaccinated children were decreased, and the immunization coverage by 59%. When we make two difference in difference analysis, that means difference in difference, we included the baseline and the underlying survey. When we see that one, the zero dose children is decreased, difference in difference analysis, 12.6, the under immunization by 38.7, and the immunization coverage is increased by 51.3, because in the control groups there was so many zero dose children, that is why the result seems very low. And what we are doing, that the other thing is what number needed to reduce or improve. In order to take out one child from zero dose, one child from under immunization, one child from fully vaccinated, just we should reach to 4 for zero dose under immunized, and relative 2 for the full immunization children. We have to reach those children with difference method. We have to reach almost 8 children, 3 children and 2 children to reach the zero dose, and we have to vaccinate such amount of child. Cost needed. When you see the cost needed from the direct method, we were using 339% of the budget to improve the zero dose child by 1%, 376% for the under immunization, and 178 for the full immunization. With difference method, it is a little bit up because there was not an intervention on the control group. Per individual, it was like this. One zero dose children took this amount of $7.66, 78.47%. Therefore, what we recommend is that establishment of the system, it's community volunteers. If it is good if community volunteers are using this referral slip to do things differently and to create demand, adopt similar intervention strategy, and maybe the need for further studies. This study may need also another further study, and the collaboration of policymakers and researchers to implement evidence-based strategies that reduce barriers to vaccination is very crucial, because with this study, we also studied the knowledge, attitude, and practice of the community that we are not plotted on this session. Thank you.
Thank you, Alan. That leaves us with the 20 minutes for question and answers. But before we want to the question and answer session, I'll want to reiterate what Devak mentioned, at least for the Indian projects. So these are very preliminary findings, and obviously, and most of the interventions are around demand, which has its issues of tangibility, attribution, and things like that. So when you're asking your questions, I understand that the figures are pretty skewed in a session, but then be cognizant that, and these are just interventions that have been rolled out for 1 or 2 months. So yeah, with that, we can take some questions.
Thank you all for a very nice presentation. The first question is for Alan. I recognize you haven't done the N-line survey yet, but in your baseline, this is before interventions have been implemented. Are there other interventions that are ongoing to reach zero dose, or how do you explain the zero dose denominator? What does it pertain to? Is it just routine services, or does it pertain to other
interventions beyond this project.
Thank you for your presentation. I'm asking some question for all presenter. As a general question, what was the cost perspective in general to clarity? If you measure or see over or underestimation of the costs, it is better to list the perspective of the cost as a general. When you reach zero-dose children, is there any integrated service with this the zero-dose again? Because maybe it is a little bit minimize the cost during the sharing. In Ethiopia, there is a multiple component with to reach a community level that zero-dose children. The other, I see, it is better to facility costs in the facility coverage for both presenter. Make sure to clarity how much cost with vaccinated children in between, other than different figures. And one question for Ali. When you measure DALI, you estimate for each vaccine, for example, Penta 1, Penta 2, Penta 3, because it is a difference of the outcome when you measure illness and the other outcome measure. The last question, so what is the outcome when you measure, for example, year of life lost or in life saving, like what is your measure? For example, in DALI, in life, for example, in Ethiopia, life expectancy, we measure is 65 years based on WHO life tools. Thank you very much.
Thank you so much. I really appreciated in the first two presentations how you separated out so carefully the design costs and the initiation costs and what I might call recurrent costs, perhaps more than rollout costs, but that was really helpful. I had a particular question, I think it was for the second presentation from Devak. I recognize that this is just a work in progress, so it was more about your plans for the future. I was surprised to see the reference to thresholds from WHO choice, because those have that 1 and 3 times per capita GDP is widely recognized as being far, far, far too high, and there's a lot of good papers out recently suggesting a very small fraction of GDP per capita is more reasonable if you don't have another estimate. And I think particularly in the current funding context, even those estimates that have been published in recent years are probably still too high. But I was wondering if you could say something more when you mentioned the global burden of disease study, whether you mean that that's where you're going to be sourcing the DALI weights estimates, or that you're actually using it for something about the disease burden. Thank you.
Should we take it right now, or should we address the questions? If it is just one, then yeah. So maybe we can take these questions.
Okay, just to start with, for the baseline costing that we did, which was the first objective, just to understand what is the monthly routine cost that is incurred to a facility. What we did was, when we were talking to, let's say, the vaccinators, the mobilizers, we were trying to understand, currently there is zero-dose children, there is cluster of zero-dose children in the catchment area that you're working in. If these children are being converted, what amount of time is being spent? So currently it's just the routine cost that we are looking into, but this is for the baseline. But we understand with the Gavi HSS activity that has been done in India, which is on the data system strengthening, which is on the CSO, which is on inclusive micro planning. The exit line is also going to have a confounding factor of about the Gavi HSS work or Gavi HSS grants work, because that also looks at the same cohort and particularly in the districts where we are looking into, and that particular cohort will also be looking at these particular behaviorally informed interventions as well as the Gavi HSS work. So we are trying to figure out a way to separate out that particular HSS grants, money incurred as compared to, let's say, what's going to be ours. So that's on the exit line. But for the baseline, at that time, there was no Gavi intervention that was being rolled out. So it was just the routine cost that was incurred in a facility just to reach a zero dose. That is the reason why the number of children was also very less. That's around 2 or 4 children that have been reached in one particular PHC that have been converted. As compared to, let's say, if I'm like downloading the monthly data from the HMIS or from the DHSI or from the HMIS system, which is around, let's say, pentavalent vaccines administered is something around 200 to 220. But the zero dose children being reached is something around 2 to 6 because the number is very less. So yeah, that's on the first.
I think there are a few points, so I'll take some time to go through them one by one. In terms of the cost perspective, we're looking at from a payer perspective, from a government perspective, how much would it charge them to inculcate that entire process within their own fold. In terms of the suggestions around sharing of costs by using interventions that also look at integrated services and not just specific to vaccination. So out of the different interventions that we're piloting right now, I think most of them address barriers that may not be relevant for other integrated services, such as if I talk about fear from AEFIs is a very specific barrier that may not be interoperable with other services. But we do have collaterals for things that may be transferable. So for instance, when it comes to migrant communities, they don't know where and when to access services. So the communication tool that is deployed for that is not only making them aware about immunization services, but where they can avail all kinds of health services and also the scheme benefits from the government side of things. In terms of DALI estimations, very rightly pointed out, one of the key gaps in the methodology that we have also been wondering about is there is a difference in antigen doses as well, and your DALI estimation will change as per the coverage across different antigens. Currently, the best way we've found to mitigate that is to depend on the default estimates within the list tool that accommodate for these variations across different doses, since we'll be using the deaths averted from the list tool to arrive at final DALI estimations. As far as life expectancy is concerned, there's a sample registration system, which is an administrative data set available at a sub-national level in India, so we'll be using that as well. On the WHO choice threshold, thank you so much for highlighting it, and it was taken up at that time as the benchmark when the methodology was being conceived, but the entire point of us coming here as well is to learn from the experts. So it's something for me to take back home as well and reflect on, and perhaps you may see a change of approach on our part as well. When it comes to the usage of global burden of disease study, you're rightly so, we're going to be primarily using it for DALI weight estimations, and there is a beautiful paper on the cost effectiveness of PRIs in India by Logan and Dr. Chatterjee as well. So we're replicating the methodology in that to convert deaths averted to DALIs averted, which looks at some net preset values and ratios for conversion of ILDs to deaths. So that's how primarily we're using the global burden of disease study. I think that's all from my side.
Okay, thank you all for the question. Just I'm conflict only for issues. Regarding the result of the independent survey, there might be a co-founding. There might be a co-founding effect also. We are not only only implement to track the zero dose children under immunization and full immunization. The government also, working with different policies. Therefore, the result may be it has a co-founding effect. The other thing, what was the most what is there any integration activity for when we are working with this zero dose referral slip? Just we try to, this project was mainly doing for zero dose under-immunized and under-vaccinated children, and we try to identify, track the zero dose and under-immunization and full immunization coverage through this referral system. We will not just integrate other services, and therefore we cannot measure other services are in proper way or not. The other thing is that regarding to the outcome, the facility, the outcome, just in this research, just we are not assess the outcome, but even if we didn't assess the outcome, we try to decrease the zero dose, the under-immunization, and we try to increase the full immunization coverage. Therefore, we said that the mortality and the morbidity rate of the children are decreased. Therefore, just the outcome level was measured just like that. Otherwise, we didn't do any analysis for the outcome level. Thank you very much.
Yes, good afternoon. My name is Alemnesh Teka from UNICEF. I have a question for the session in general, and not specifically to you guys. Just to understand, when you say community-based demand generation interventions, I assume that in your presentation you had to sort of cut some of the contents, but how do you identify and prioritize the interventions that you are implementing in following? Because I'm sure when you consult with the community, there are 25 interventions that they will be interested in and they see and support them. And one of them is cash incentive. I didn't see anything around that in the presentation. It would be really interesting to see how do you prioritize. Is there a way to do that? Or is it some sort of donor-driven type of intervention that we bring in, but then we sort of consult the community and proceed? Thank you.
Yeah, maybe I can take that. The community-based demand generation interventions that we're talking about is, having all the stakeholders together, all co-creating with all the stakeholders, as in we bring together zero-dose caregivers, we bring together EPI officials, we bring together religious leaders, healthcare workers, community health workers, we bring them all together. We talk to them, let's say, in particular ways of talking about particular case scenarios, particular barriers, so that they are addressed. And in that particular scenario, what happens is we do get a list of n number of ideas and maybe solutions on how we can move ahead. So, for example, we had something around 32 interventions that we had, we had got from all these co-creation workshops while we had developed. But what we realized is when we did pilot testing, or maybe when we did field testing, we were also going back to all these stakeholders. We were trying from a lens to understand the potential impact of this, but additionally we're also looking at the feasibility or maybe the pragmatic sense in which, let's say, if we package it towards and maybe give it towards the government for the policymakers to take it up and roll it across the particular area. That is when many of the interventions were, the scoring was very much less, and that's the reason many of the interventions were dropped. Even the conditional cash transfers, and also, this was one of the interventions that had also emerged from all these co-creations, that we give us some money, or maybe give us some lentils, maybe at that time maybe we'll get ourselves vaccinated. But again, the potential impact for that is, from a policy lens, that has a lot of unintended consequences that might arise. As in, when we stop these conditional cash transfers, what happens next? There might be a backsliding of the coverage that has happened from this conditional. This was just one of the verbatims from one of the EPI officials that we had gotten. So yeah.
So if I can just quickly chime in on that, is I think we've tried to stay away from the process as much as possible, in the sense that it's very community driven, be it from the inception point of creating a lot of ideas. They were primarily coming from community members, influencers, healthcare workers, and as Anand highlighted, it was a big pool of ideas that eventually, when it comes to prioritization, in the case of UP and Bihar, it was done primarily by system stakeholders, program managers that were called into workshops where each intervention was discussed in detail, and pros and cons were weighed, including cash transfers as well. And again, sustainability concerns were the primary concerns that were highlighted, which is why it perhaps didn't sail through. But also to evade any sort of hierarchies within government administrative folds, also eventually the prioritization matrix followed anonymized voting as well within these workshops. So that's how we ended up prioritizing the interventions. And the last leg was, from that pool, you also do one layer of low fidelity prototype testing to understand whether it's feasible on ground to implement that solution or not, and then eventually high fidelity prototype testing, which is how we arrived at the current interventions.
If I may just add or rather summarize, no, these were not donor driven. The entire methodology has been very community inclusive and all stakeholder inclusive. The approach has been varied with we have 3 projects. We have 3 projects running in India, and even the laundry list of interventions has been co-created with the community, like both the projects mentioned. And then the prioritization, feasibility, all that has been done with all the stakeholders, be it program managers, be it community, be it implementers. The model of engagement has varied. Like sometimes we have leveraged a heterogeneous group to come up with decisions of what looks feasible, what looks most impactful, and sometimes it has been like a homogeneous group deciding and conveying as to what works well. So that has been the approach, and it's not a very top-down approach. It is that I can vouch for ZLA. So yeah. Any more questions? Yeah.
Sorry, can I follow up on that?
Sorry? Yeah.
Just 2 minutes to follow up. I think we need to also clarify what we call community in this conversation. When we say community-based, what I hear is communities themselves, the beneficiaries of interventions. The people who don't go to church on Sundays, this is what I mean. If you are referring to the stakeholders in terms of the practitioners, in terms of the provincial medical directors, they don't have the same interest, they don't have the same needs, and therefore the prioritization that they will make is not necessarily adapted to the community. So that is what is governing. So once you have finished prioritizing, is there a session where then you go to the real community to feedback and to hear what they think about the result of your prioritization. And that's what I didn't see in the presentation, and I would like to hear more about it.
Yeah, so before you start, that is not reflected in the presentation because that was not the idea of sharing the entire process of how this project has rolled out. It was just limited to the financial and some of the programmatic implications. Otherwise, we can have a separate session on the zero-dose learning agenda processes. And yes, the communities have involved all the stakeholders, be it the people as well as the program managers. I understand that all of us were cognizant that they have different interests and different thinking processes. The other thing which you very rightly pointed out on was that whether we go back to the community to understand how they are feeling about it. So that is a very key element of this zero-dose learning agenda project, and my colleagues can build up on that how regularly you go back to the community and understand and also tweak the design and the intervention package according to their requirements to have that maximum impact as well as the ownership, because once they are opining on the intervention, it becomes very necessary that you also adapt it as per their opinion. So yeah, please, if you have time, we can add.
Maybe we want to ask a few more questions, right?
Okay, and then maybe we can connect on the ZLA approach after this session. But yeah.
Who else?
There was a question raised earlier, I think you raised it, about the technical assistance costs. And can you maybe talk a little bit about how integral the technical assistance is? Like, could the interventions have been designed and implemented without the TA? Or how critical was it?
last question.
Yeah, maybe.
This is Aman Singh from ADB. I was thinking, when I was looking at the unit cost of reaching a child. Does your studies, and I was looking at the cost where you have shown the cost of the TA, the design. But whenever we are trying to demonstrate an intervention, we're trying to institutionalize it, there are going to be additional costs. Does your studies will show a number in the end that this will be the peacetime cost? We're hoping to institutionalize them as part of the national immunization strategies. So in a routine, like a normal period, this will be the unit cost, so that we can compare apples to apples, the cost of the RI. Because as a donor, I would like to know if my investment is going to institutionalize these new interventions, or has it already been integrated, and now I'm only talking about the scale up and just reaching the missing children.
So starting out on the criticality of the technical assistance that was provided. So it's a very novel approach from a government perspective as well, because so far they've just been hearing about system side challenges and less so about demand side interventions. So to walk them through the process, to build their confidence over the process is something that was very critical to its success as well. So I would say the TA support was encompassing across all phases, not just starting from, it's not just restricted to high level strategic frameworks, but when we call it TA, we are also referring to sort of mobilizing beneficiaries for workshops, making sure what the workshop design looks like, making sure all logistics are in order. So we've taken an expanded definition of TA support. On the question of whether all of this can be done without it, I would say in part yes, in part no. There are some things that cannot be done and will need to get institutionalized into the government fold, which is what we will benchmark in our models going forward. There were elements that, of course, these costs could be inflated because it was a first time approach that we were also testing out. So we would also want to get rid of those costs as well, which is a good segue into the second point around are we considering the scale up of the existing interventions that have been developed and we're coming at the cost effectiveness threshold, or are we looking at the cost effectiveness of institutionalizing such frameworks in themselves? I would say the final output that we're looking at would serve both purposes. Because one is, if the government is interested in scaling up the existing communication collaterals developed, then we have the cost ready for that, and you can choose the subset from the superset to understand, okay, what would be the rollout cost specifically for this intervention and scaling it up across, say, all 75 districts in Uttar Pradesh. But when it comes to, that's why we've been so rigorous to also cost the entire process when it comes to designing phase. If you want to pitch for the government to inculcate the entire HCD-based process within their fold as well, what would be the cost to them for that? So I would say our study would cater to both of the outcomes that we're looking at, because we realize that at the end of the day, it's very important for a sustainable transition beyond a project as well. So that's what we're aiming for as well, that can guide such policy level decisions. Yeah, and if you want to add on.
Yeah, maybe I just maybe add on a bit. So for the design component of things, TA was the integral part, considering that HCD is something that's not something that is been there in the systems, or maybe that is where we have engaged design researchers and so that we develop such bottoms up approach in order to understand the contextual barriers of what is driving these zero-dose children to exist, or what is the reason behind these zero-dose children. So in the design point of view, this TA was a very integral part, but again, in the early rollout phase is where we see that the TA can be, let's say, once we roll it up across in one of these areas, and maybe we support the government staff in conducting such trainings, that's where maybe TA might not be such an integral part. So, and also generalizability from The JSI lens is partial, considering that we work in an urban areas, specifically in the urban high zero dose burden area. That's where we are looking into it. So again, our approach has a twofold approach. One of it being institutionalizing this HCD-based approach to reach zero dose children, and also with this approach, we have developed certain interventions which have been showing some potential impact, potential number of zero dose children being converted, being vaccinated. Considering that these were very resistant and resistant families who were not, after let's say 2, 3 nudges, 4 nudges, 5 nudges, mobilizing, going and trying to do house to house surveys, house to house mobilization, still they have not been vaccinated. But again, these behaviorally driven interventions have been able to convert them. So this model is something that this approach, the whole approach of HCD, the whole approach of ZLIFE, what we would want, from a government perspective to, take up rather than particular interventions per se.
Okay, thank you very much. Just regarding to our approach for our approach in a referral sleep, just we said that we laid on the community because just as a group partners project we are working all immunizations meeting with the community. That means that we are working with the religious leaders, clan leaders, with community volunteers, and we prioritize that this referral sleep was working with the community volunteers, and the community volunteers are, they are connecting the public and their care provider in between. Therefore, just we said that we done this project through the community-based intervention, and as well as we create demand through house visit from the community regarding to the immunization. The other thing I want to reflect is that we were having around $11 million for this project specifically, and for the more than 60% of the money was going to the program, to the programs, that means to train the community volunteers, the health station workers regarding to the referral sleep, and to have the monitoring session, supervision for the direct costs. The other 70% of the grant was going to the for indirect cost, and a little bit of salary for the zonal coordinators, and for the overhead cost for the communication and so on. Thank you very much.
To summarize very briefly, there are emerging models which will need to be developed going ahead of and planning the sustainability plan and transition plan of the entire activities. And with that, I think thank you for the presentations as well as answering all the queries the audience and be back and see what else we can.